panel, we will hear from three medical experts on the health consequences of fentanyl and fentanyl analogs. Our panelists are Dr. Brian Brown, Dr. Roger Mitchell, and Dr. Howard Haft. Dr. Brown is the chair of the University of Maryland Emergency Medicine Department and oversees a staff of 75 faculty members and 50 residents. He developed the Maryland Emergency Medicine Network, which encompasses 14 emergency departments in rural, suburban, and urban communities in Maryland, where 550,000 patients are treated every year. Dr. Brown has published numerous articles in medical journals, and he is a frequent speaker at professional forums in the United States and abroad. He earned his MD from the State University of New York Downstate Medical Center and the College of Medicine, and did his residency in internal medicine at St. Vincent's Hospital and Medical Center. He earned his Master's of Science from Niagara University and Roswell Park Memorial Institute, and his Bachelor of Science from Syracuse University. Dr. Mitchell is the Chief Medical Examiner for the District of Columbia. Previously, Dr. Mitchell served 2 years as the Regional Medical Examiner for the Northern Regional Medical Examiner Office in Newark, New Jersey, and served 4 years as the Assistant Deputy Chief Medical Examiner in charge of medical legal death investigations at the Harris County, Texas Institute of Forensic Sciences. Dr. Mitchell has performed over 1,300 autopsy examinations and has testified as an expert in numerous cases. He is a graduate of Howard University in Washington, D.C., and the UMDNJ New Jersey Medical School in Newark, New Jersey. He performed his pathology residency at George Washington University Hospital, where he served as chief resident. Dr. Mitchell is board certified in anatomic and forensic pathology by the American Board of Pathology and is a fellow with the American Society of Clinical Pathology and the National Association of Medical Examiners. Dr. Haft is the Deputy Secretary for the Maryland Department of Health and Mental Hygiene. Dr. Haft has 27 years of clinical experience in primary internal medicine and 10 years of hospital-based emergency medical, clinical, and leadership experience. He has served as an adjunct professorial lecturer at the Georgetown University McDonough Graduate School of Business. He has served as co-chair of the Maryland State Medical Society Physician Leadership Committee and has served as a member of the Maryland State Telemedicine Advisory Committee, several Maryland Health Services Cost Review Commission committees, and the Maryland Health Care Commission advisory panels. Dr. Haft earned his medical degree from Penn State University and completed his internship and residency in internal medicine at Brown University. We will begin with Dr. Brown.
Members of the United States Sentencing Commission, it's my honor to speak to you today about the problem that has strong negative impact on the Baltimore City, the illicit use of fentanyl. Fentanyl has a place in the physician's armamentarium, especially in the emergency department, where I and my colleagues use it regularly to treat acute pain and provide sedation. However, the arrival of illicit fentanyl has had a devastating effect on the state of Maryland. There were 29 fentanyl-related deaths reported in 2012. 2016, that was 1,119 fentanyl-related deaths in Maryland. This trend seems to be worsening because the state health department reported there were 799 fentanyl-related deaths in the first 6 months of this year. More than a third of these deaths, 35%, occurred in Baltimore City, where I and my faculty practice. We have seen a steady increase in the number of patients coming to our emergency departments as a result of opioid overdoses. And while Baltimore City has struggled with the issue of heroin for some time, fentanyl adds a substantial burden to an already disadvantaged community in our medical system. I'd like to supplement what I've handed over to you with just a couple of examples of what we're talking about. The first is a 54-year-old grandmother. Her family found her poorly responsive and on her bathroom floor. They called 911. When the paramedics arrived, they recognized the signs of opioid overdose, gave some naloxone, transported her to our emergency department. As she responded to treatment, she became more alert. She was able to describe what happened. Turns out that she had been using heroin for more than 20 years. This was the first time she had ever overdosed. She stated that she had always bought the same amount of heroin, the same dealer, on a daily basis for years. However, on that day, she bought some from someone else, and not the usual source. She didn't notice any differences until she insufflated the powder and then lost consciousness. The story is typical of many of the steady opioid users in Baltimore. Many have been using steady, constant amounts only to accidentally overdose because unexpectedly fentanyl has been in the preparation. My second story relates to a 24-year-old woman who recently moved to Baltimore from upstate New York. She'd been in the area for a few months, decided to go to a concert with some few friends. Halfway through the show, friends noticed that she had been gone to the bathroom too long. They had security open the stalls where they found her with a needle in her arm without a pulse. Chest compressions were started, naloxone was given, EMS transported to our emergency department, but there, despite our best efforts, she never regained consciousness or a pulse and died. It's terrible, really, to inform the mother that our only daughter is dead. Her father told us that this was not the first time that she had taken a problem with drugs, but that she had been sober for several years. Stories like this have become common in Baltimore, where patients with substance abuse problems will relapse as part of the disease of addiction. But now with fentanyl mixed in, the supplemented heroin, many users who have been sober will overdose when they relapse because it's so much stronger and more dangerous. My last story is about a 34-year-old mother of three and a nurse in our emergency department. She was working one weekday afternoon when the EMS brought in a young man who had apparently overdosed. He was unresponsive. EMS gave him some naloxone. The patient became very alert, as expected, but then began to hallucinate, became combative. EMS had to strap him down in the stretcher. When the nurse, who had not seen this young man before, walked over to take the patient's vital signs, the patient spotted her, slipped out of the restraints, and chased her around the emergency department screaming, "I never meant to hurt you." She was able to safely barricade herself into the bathroom while security, was able to restrain him. But the patient had to be, had just been revived with life-saving medication, had to be sedated all over again. These reactions pose a clear threat to the patients and everyone else taking care of them. I'd like to summarize by saying that illicit fentanyl has had a strong negative impact on Baltimore. There are steady users who believe they are buying heroin but accidentally overdose because they've given fentanyl instead, or fentanyl-laced heroin. There are those patients who have been sober for a while, relapse and accidentally overdose when they are now exposed to fentanyl that they've never been exposed to before. And lastly, they're seeing patients with this apparent opioid overdose who become dangerous to the medical staff once resuscitated. I think that there are probably 1,100 other stories, but I want to highlight these because you might not have thought of this series that we're taking a look at. Thanks very much for your time.
Thank you, Dr. Brown. Dr. Mitchell.
To the Honorable Judge Pryor and the Commissioners, I want to thank you for inviting me here today. I'm humbled to share my thoughts and expertise surrounding this opioid crisis and the perspective of the medical examiner. One thing that I wanted to add is that I also sit on the National Association of Medical Examiners Strategic Planning Subcommittee, where we handle and analyze the strengths, weaknesses, opportunities, and threats to the discipline, as well as to the organization. And the opioid crisis is a definite threat to the National Association of Medical Examiners and the medical examiner system. And I'll be highlighting that throughout my testimony. In the short time that I have today, I'll clarify the role of the medical examiner in the response to the opioid crisis. I'll give some background as to structure and function of the opiates in the human subject, and how it imposes its lethal effects on the body. I'll provide some general national statistics that you may already know, and then I'll focus on the straining effects of the epidemic on the medical examiner system, and talk about some highlighting challenges to the District of Columbia. Most medical systems, medical examiner systems are 24 hours, 7 days a week. The role of the medical examiner is to investigate all unnatural, sudden, and violent causes of death. The investigation normally includes scene documentation, body transport, medical chart and police document review, full and partial autopsy examination, and the toxicological testing, all for the establishment of cause and manner of death. There are 5 manners of death. There are homicides, suicides, accidents, naturals, and undetermineds. Opioid drug overdoses in this country are to be considered and usually are considered as accidents, therefore fall directly under the jurisdiction of the medical examiner or coroner. Let's put this in perspective. In late 2014 and late 2015, early 2015, we started seeing this uptick in these opiate overdoses. There are now more than 33,000 deaths due to opioids each year in this country, including the prescription opiates as well as non-pharmaceutical fentanyl. As a matter of fact, the CDC has called that there are 91 Americans that die every day due to this crisis. So the medical examiner system is in a unique position to understand the crisis the way others may not. And so these 33,000 deaths annually and these 91 deaths every day are investigated, examined, and certified by the local coroner or medical examiner. The drug mixture profiles found within the bodies of the overdose victims are being identified by the toxicologists and pathologists of these local jurisdictions. So these are drug profiles that are not often able to be identified in the normal hospital setting. The medical examiner offices all over the country are being inundated by these deaths, and to the point in which national accreditation is being challenged. Many of our offices are losing or downgraded their national accreditation because of the number of deaths per doctor. Each doctor has a prescribed number of autopsies that you can do each year, and it's important to stay under that number or you will lose your accreditation. Although the Office of the Chief Medical Examiner in D.C. is not at that risk, we have seen a 178% increase in the number of overdoses from opiate use disorder between 2014, when there were 83, and 2016, when there were 231. This doesn't seem to be decreasing in the foreseeable future. If we keep on the rate that we are in 2017, which were about 216 by September, then we're scheduled to have about 1 per year, so over 300 opiate overdose deaths in the District of Columbia. The majority of DC OCME cases are mixed drug toxicity that came in other testimonies. 70% all deaths have heroin, 72% all have fentanyl or a fentanyl analog. The highest number in 2017, in August, there were 88% of the opioid overdoses had a fentanyl or fentanyl analog on board. So we're seeing many of the fentanyls: fentanyl, norfentanyl, acetylfentanyl, fentanyl, the fentanyl precursor of 4-ANPP, and then we're also seeing U47700 as well as carfentanil, the known elephant tranquilizer. Why is this important? Well, we know that fentanyl is 50 to 100 times more potent than morphine. And it acts on the respiratory centers where it really sleeps you to death. One of the things that we're seeing on scene now that we've not seen before is, and it's spoken back at another part of the hearing, is that the syringe is found on scene. These users are not able to put that syringe away. They're, what I say, is dying at the edge of the plunger. We have a program here in DC where we're actually taking those syringes and having them tested to see whether or not we can see anything different in the syringe that we're seeing in the body. We have some preliminary results that I can talk about. One thing I'll end with here is that the nation is seeing this opioid crisis in the 20 to 35-year-olds. 80% of the opioid overdose deaths are 20 to 35-year-old white men and women. But here in the District of Columbia, and Dr. Brown alluded to this, is that we're seeing the 50 to 60-year-old black men that are dying from opioid overdose deaths. And so they're known heroin users, have been using it for 30 years, and now are getting the fentanyl-laced heroin and are dying from that. So there's no single solution to this problem. There'll be a need for a multidisciplinary approach to this public health issue to sustain positive outcomes. There is no doubt that there is a need to support the addition of more medical examiners and toxicologists in order to deal with this issue. But this solution will entail improved availability of in-treatment, prevention, testing, and deterrence. And again, I want to applaud the commission for taking time to gather information from a multiple of sectors as you develop a response to this very important public health issue. I'm available for questions when that time comes. Thank you.
Thank you, Dr. Mitchell. Dr. Haft.
Acting Chair and Commissioners, it's a great pleasure to be here today and be able to provide some hopefully meaningful testimony regarding this public health crisis that we're in the midst of. As you know, there's been a dramatic increase in the number of deaths from unintentional opioid overdoses in the past several years. You've heard several people testify about the magnitude. The CDC even reports that there may be more than 50,000 deaths in the prior year from unintentional opioid overdoses, which overshadows the total number of people who died during the entire span of the Vietnam War, and is clearly an enormous crisis. And sadly, this is just another example of how financial gain by some overshadows the concern for the health of the public. I want to comment on four things that I think really are relevant now, and then be open for questions. Number one would be the potency of this particular drug and its similar congeners. Number two is the cost. Number three is the fact that it has, in terms of the addiction potential and the attraction that it has for individuals who happen to be suffering from substance use disorders. And then a picture of what the future might look like, what the present is and what the future might look like based on what we know now. And first, in terms of potency, it's very clear that fentanyl is much more potent than heroin. It's 50 times more potent than heroin. And in fact, I think your toxicology testimony previously said that as little as 1 milligram of fentanyl can be lethal. 1 milligram is a tiny amount. But then we look at some of the other more designer versions of fentanyl, like carfentanil, which is 1,000 times more potent than morphine, in which 50 micrograms, which you couldn't even be able to see 50 micrograms, but that's lethal. And then there are drugs that have been produced already in labs for many years and could be on the fast track to be even more potent than carfentanil, like omfentanil, which is 6,300 times more potent than morphine, and less than 1 microgram of that could be fatal. So we have a very potent group of drugs that are easily produced by backroom chemists. But the costs of those drugs is really what drives the death and the lethal factors in this epidemic. And that is that there's a strong advantage to individuals if they can produce a more potent drug cheaper and sell it cheaper than heroin or sell it cheaper than OxyContin. So for instance, fentanyl at the street level cost about $2,000 per kilogram, $2,000 per kilogram. Heroin is about $64,000, maybe as much as $100,000 per kilogram. So fentanyl per kilogram is cheaper, but the potency factor really leverages the value of that in the producer's mind. And if you take a kilogram of fentanyl, you can produce about 500,000 2-milligram pills. It would look like OxyContin or some kind of pill to get people high, with a street value of $10 to $20 for each of those pills. So we're talking about on a $2,000 investment, $5 to $10 million worth of street value. That's dramatic. That's an incentive that drives a lot of illicit behavior. And then there's this other paradoxical thing, is that people who are in the throes of addiction, who have substance use disorders, those individuals are driven by a biological urge. I mean, these drugs, like fentanyl and carfentanil, bind to the mu receptors in the brain, which release dopamine to an area in the brain which it develops euphoria. But it's one of those really primitive areas in the brain that are responsible for our basic biological urges, also like hunger and thirst and breathing. All of those are compacted around the same areas. So when people get these drugs, they bind to these areas, they release this this substance, this dopamine substance. It gives them a euphoria, but it makes them absolutely need to come back to that again. They're strongly driven to come back biologically. They cannot resist it. It's the nature of addiction. And these drugs are more addictive than heroin or OxyContin. So fentanyl is more of a high for individuals who want to get drugs. So even though they may understand there's a risk associated, it's still the good stuff. So they may, if somebody's selling the good stuff, not the heroin users who've been using heroin, as was recounted here, for 20 years in DC, but the newer individuals who've come on the train of being addicted to oral opioids, they will look for these selectively better highs. And it's like Russian roulette, because as you've heard before, the admixture of these is hardly anything that's scientific. Whether it's a little fentanyl or a lot of fentanyl is unknown to the user, probably unknown to the person who's distributing it to the street, only known to those individuals who are producing it in China or Mexico or wherever that might be. So that's the next part of this, is that these are so strongly addictive. The last part is what we have to see in the future, and that is the fact that by some estimates, up to 4% of individuals 11 years old or older in this country have some degree of substance use disorder or addicted to opioids, because we've flooded the market over the last 10 or 15 years. We've been giving OxyContin and other long-acting opioids to treat pain when we should have been doing perhaps other things. End result is enormous number of people now are in the throes of substance use disorder who may be still using OxyContin, but many of those will march down the pathway from oral OxyContin and oral opioids when they find that they're no longer available, because we've appropriately tamped down on the distribution of those, and that they become expensive on the street, that they can get heroin that's cheaper, far cheaper than OxyContin. And that heroin then is admixed with fentanyl and carfentanil and other things, and it becomes absolutely like Russian roulette. So we're just seeing the tip of this epidemic right now, as those additional people, those 10 or 11 million people in our country who suffer from substance use disorders, become more exposed to heroin and to fentanyl. The death rates will continue to rise. So it's up to us to doing something about it. And this is absolutely a public health crisis. Thank you for your time.
Thank you, Dr. Haft. Questions?
I don't know if it's possible to know whether or not the harm to the human body, does it vary between fentanyl and the analogs, or what you see, do they have different effects on health outcomes for people?
So absolutely, in terms of the potency, so that exposure to carfentanil, even a casual exposure to carfentanil can cause death. I think that's the big harm. And what we're talking about in terms of harm for all these drugs is that they unexpectedly cause sudden respiratory depression. So within a minute or less, you stop breathing. Within 3 minutes, you're dead. 5 minutes, you're brain dead, and it's all over. So not even enough time many times to give naloxone or other kind of life-saving interventions.
But that would be key to the potency then. So
Key to the potency.
we'd have to know how potent, and then we'd have to know how much somebody actually ingested to know what.
Let me be clear. Here in DC, again, we were chugging along at about 80 or so heroin deaths a year, and now we're at 231, close to 300. The balance of them have fentanyl. So fentanyl is the culprit. I mean, we've had heroin addiction in this country for centuries, and this uptick that we're seeing is fentanyl directed. And like you've heard before, the amount of fentanyl in the heroin, all of that is very difficult to understand. I just spoke with my epidemiologist who came with me. I said, that's another study we need to do and figure that out. But fentanyl is invariably in the reason why people are dying at the highest rate now.
When this stuff is made, it's not being created by professionals, expert laboratory. That's street pharmacists, and quite frankly, the adulterants. There's no quality control, and so from the source, it's not known how much it is. The mixture with heroin or the adulterants, and its mixture is not known. It's not homogeneous even in the preparation they might have. And so a lot of the cases I gave, they were unknown. But there are people who know they're about to use this stuff and it's been laced with something stronger, but they don't even know what it's going to do. Well, they don't know from one shot to another it's the same or different. It's extremely lethal, no matter what you're mixing it with.
Judge, go ahead, Judge.
The injuries that you're seeing, in addition to deaths, you're seeing injuries, strokes, and other injuries that you see from lack of oxygen to the brain.
So the ICUs in many of our hospitals, the intensive care units in many of our hospitals, are now filled with people who are on respirators, who have brain death or other kinds of serious conditions, who were resuscitated but not completely resuscitated. So the tragic consequences of that, the economic consequences, all those things are yet to be counted.
Dr. Brown, I think my question is probably for you, and it relates to naloxone administration.
Yeah.
Could you explain how, I've always wondered how that process works. How does naloxone work? And also whether you're seeing that with these fentanyls, you're having to do more naloxone than you have in the past with heroin overdoses.
Yeah, there is receptors, opioid receptors in the brain. It's not a coincidence that here are the drugs that work on those receptors that are naturally in the brain. And these various drugs, heroin has a certain affinity for those things, and you have an effect. These fentanyl, intensely stronger, greater affinity for those same receptors. Naloxone competes. It attaches to the same receptor. By attaching it without the physiological effect, it competes and blocks the other one from having the effect. For heroin, we got used to a certain amount of naloxone. You give it to them, and quite frankly, predictably, they wake up. It lasts longer than heroin, and so they do pretty well. In fact, many of the EMS community were given really small amounts because they didn't want their patients getting so sick. They just want them to be revived and come to the ED. So it was very small amounts. Without clinically knowing that it's fentanyl, you find that suddenly now the paramedics are realizing that they give some and it's not working because the intensity and the strength of the fentanyl and the analogs is binding and stronger. So they have to give more of it. They have to give more, and so all of a sudden they realize that they didn't test for it, but the clinical circumstance is indicating this is not the usual narcotic overdose, opiate overdose. They're giving a great deal more, and it doesn't last as long. So they have to give more of it or infusions. So the amount that we're having to give of Narcan is just a proxy that you are now dealing not with heroin any longer, but with something else in it. I spoke to the chief of EMS in the city of Baltimore just yesterday, anticipating coming here today. He said a couple of years ago, his budget, his annual budget for Narcan in Baltimore was about $600,000. That's a lot. That surprised me. That's how much it was. At the moment, it's over $900,000 and going up. That's a substantial increase in just the amount of Narcan being used in order to revive or get some effect for these patients.
Judge Breyer?
Yes, I have a question of Dr. Mitchell, but maybe there are others who want to respond. Dr. Mitchell, in your written testimony, you say the following. You say, according to the Centers for Disease Control and Prevention, CDC, there are now more than 33,000 deaths due to opioids each year, including prescription opioids, heroin, and non-pharmaceutical fentanyl. As a matter of fact, the CDC reports that 91 Americans die every day from the use of opioids. So I take from that, obviously, we have a terrible opioid crisis. What I'm interested in is whether there are any statistics that show what percentage of the 33,000 deaths are due to non-prescription fentanyl as distinct from overdosing or suffering the effects of prescription drugs. Because, I mean, I'm sure you know there are many lawsuits that are presently pending dealing with the use of prescription opioids. And obviously, a number of them cause some percentage of these deaths. So we're addressing today, as I understand it, the non-prescription use, the fact that fentanyl may be in heroin and sold illicitly. Do we have any statistics that show what percentage of the deaths are the non-prescription?
So that's a really, really good question, because the circumstances surrounding the drug use and drug overdose and deaths are often not recorded on the death certificate that is giving us these statistics. Many of those statistics we can understand through the circumstances. So the majority of my fentanyl deaths are illicit fentanyl that is found admixed with heroin or being used purely as fentanyl illicitly and non-prescribed. Not clear whether or not those fentanyl at some point was diverted as a function of the prescription supply diverted illicitly or manufactured illicitly. There's a series of non-pharmaceutical fentanyls that you just cannot get prescribed. And so when those are listed, you know that those are indeed illicit fentanyl analogs. And so you can surmise that without the circumstances. One of the things that the CDC and the National Health Statistics is vying against is that medical examiners and coroners are not listing each drug on their death certificate. And so they're using terms like mixed drug toxicity, accident, and not listing them. And so once that's done, there's no way for national statistics to delineate whether or not it's a fentanyl analog, whether it's heroin, cocaine, or above. DC actually is the best at listing those out. That report just came out. And so that's what I would answer to the question. Local jurisdictions would know it, your circumstances would know it, but when it gets to the national level and you're bringing those 33,000 deaths and those 91 a year, at that level of the statistics, they're not going to know it.
Dr. Mitchell, didn't you say earlier that you were going along at about 80 deaths a year that you were attributing to overdoses or to heroin, and then suddenly it's up to 231, almost a 3-to-1 or three times increase that you attribute to fentanyl or the analogs?
Yes, so the majority of that increase we're seeing are fentanyl, have fentanyl on board, and we can fill the gap with the fentanyl increase.
For years in Baltimore, I'm staffing 5 emergency departments in West Baltimore. We saw about maybe 1 overdose death every other day, predictably, and you can see that number. We're seeing 2 a day now. That's a substantial increase. The numbers of opioids, prescription opioids that are causing these deaths has been remaining pretty flat over the years. And the sudden increase that we're seeing, the speed with they're going, from a clinical point of view, it's painting a different picture. That suddenly there's more Narcan being used. This is characteristic of fentanyl. But I have to admit, we're not actually testing all the time because it's not adding to the treatment. It would be great to know, I suppose, but not adding any knowledge to that particular case. So that specific information is a little lacking.
In regard to Maryland, so the Chief Medical Examiner's Office is in my administration in Maryland, and I can tell you that the increase seen in deaths, which has been now over 2,000 last year, was entirely fueled by fentanyl. We find fentanyl in deaths with heroin, we find it in deaths associated with cocaine, we find it in deaths associated with virtually every other drug. So fentanyl is the thing that is being used to juice pretty much every illicit drug that's on the street. And the majority of cases we see with unintentional overdoses from opioids, fentanyl is the root cause.
Right.
It's increasing the deaths by a factor of 3 to 4 times.
Yes.
Yeah, and what I want to add is that you can't forget, however, the increase of new users. So that is a variable, because if you have new users in the system, then you can have more deaths in the system as well. So it's going to be fentanyl to potency, but the variable of new users is quite, as well unknown and need to be taken into consideration.
Any other questions? Okay. Thank you very much, Dr. Brown, Dr. Mitchell, Dr. Haft, and for your oral presentations this morning and for the written submissions you provided earlier that will be part of our record. We appreciate you being here to help us today.
Happy to do so.